Welcome to this academy. Welcome to this web meeting of the Academy Hour sessions that our educational committee promotes. My name is José Manuel González Meijome. I'm the current Vice President of the European Academy of Optometry and Optics and former member of the educational committee. With us is also our President, Rupal Obel Patel, and also our distinguished speakers and collaborators. First, I will introduce Pascal Blazer. Pascal is representing Hoya in this session. Hoya is our distinguished educational sponsor for several activities, so including Academy Hour sessions, special interest groups, and also in our annual meeting. Next meeting will be in May. We will also inform about that in the end, in May, in Ljubljana, Slovenia. And we hope all of you will attend that meeting. Pascal is going to address you with a few words, and after that, I will pass the word on to our first speaker, Max Aricochi. Max is an optometrist practicing in Innsbruck, Austria, with a focus on myopia management. His master thesis resulted in the creation of the first logbook on myopia management in German language, and he's actively involved in the Kevin Brook Eye Center, where he managed optometric care, contact lens clinics, and myopia management services. He is known for his innovative approach to complex patient needs and his commitment to improving clinical practices in myopia care. After Max, Dr. Daniela Goichea, who is an ophthalmologist based in Bucharest, Romania, will address us with his cases. She has extensive experience in orthokeratology and myopia management, has successfully treated over 10,000 patients, including more than 1,000 children fitted with orthokeratology and soft contact lenses, multifocal contact lenses. Daniela has also served as a trainer and speaker for numerous national and international conferences and coordinates the Southeast European section of the European Academy of Orthokeratology and Myopia Control. She works in organizations like the Myopia Day and is very active also in outreach activities. So it's a beautiful panel. Thank you, Hoya, for helping us to put this together. And now, Pascal, the floor is yours. Thank you very much for this continued support.
Thank you very much, Jose, for the introduction. Let me quickly share the screen for some slides for this introduction. Let me see. Can you see now my screen?
Yes.
Okay.
Pascal.
Okay, good. Thank you very much, Jose. So yes, a warm welcome from Hoya Vision Care and from my end to this webinar with the European Academy, the EAO, and many thanks, of course, for the organizer, Rupal, Christina, Daniela, and Jose for doing this nice moderation. A special thanks, of course, for Daniela and Max, who will present their special cases from their daily practice today. And I want to tell you why we choose the opportunity to have these experts presenting clinical cases with MyoSmart for this EAO webinar, and that is Hoya sponsoring. So for more than 2 years, we have been running a very successful confidence to evidence campaign, which is based on the large number of studies and ongoing work to provide more scientific evidence for efficiency, but also for functionality of MyoSmart. And thus, we want to strengthen the confidence in our products for practitioners, prescribers, and associations. To date, there have been more than 50 released studies on MyoSmart. So you can access them via the code. And these scientific studies can show many scenarios from the practice, but it can corresponding to recommendation to how to use MyoSmart. But however, as children are individuals and have different life and visual situations, each case can remain unique and cannot always be supported by any randomized study. Therefore, during the IMC, Hoya launched a new campaign this last year, which aims to give practitioners even more confidence in dealing with myopic children in their daily practice. I am therefore presenting this new campaign to you today, the confidence in practice. The kickoff was during the IMC in Sanya. During this unbelievable conference in China, not only the latest studies in myopia management were presented, Hoya organized the first international case contest to hear the voice of practitioners to the international guests. Hoya invited prescribers and fitters around the world to send their case studies to Hoya for applying to the contest. The 5 finalists from Australia, China, South Africa, and 2 from Europe, Max and Daniela, were invited then to Sanya to present their cases to the panel of experts and the audience. And here you can see a little summary or impression of this case contest in Sanya.
This is the wonderful event that will help us to learn from you, and we'll do our best to translate the knowledge and expertise throughout the world.
It's important to measure axial length and use a growth chart that dictates the need of the treatment.
I took this myopia case because I want to protect him from the genetic consequences that his family has faced over the years.
Patients that 4 years old, single vision glasses cannot help very much. Eyeballs X-ray grew very fast at 0.9 for 2 months.
Early intervention for me is crucial, especially if I have a case with a high-risk profile. I do not wait for the myopia to progress. I start right from the scratch.
If you look at the potential of what or how bad his prescription could actually become, it creates a sense of urgency to do something today.
So even we know they are back now from China, and we have the 5 experts, and all of them are the winners. The contest was such a success that we have decided to take the concept of sharing practical experience further into the different countries and regions. That is why we are here today. And with us, we are 2 finalists from Europe, Daniela and Max. I'm delighted that the 2 experts have prepared even more cases for you for this evening, and you can have a look and you can see how they will present in 1 hour a lot of cases and practical informations. So back to you, Jose, and enjoy this evening.
Thank you very much, Pascal. Very nice introduction. Such a way to start. Thank you very much. So now all our attendees understand why these 2 persons are here. So they have been selected in a very competitive context in the largest world myopia conference. So congratulations, Max and Daniela, first for your achievement. And thank you for accepting our enthusiastic invitation to be here and share your thoughts, your knowledge, and your extensive clinical experience. So Max, without due delay, please start sharing your cases with our attendees. We will be collecting the questions on the Q&A facility at the bottom of the Zoom session, and we will pose these questions to our attendees again. All question, do it in the very concise way so we can post as much as possible questions to our attendees in the end of the session. Max, the floor is yours. Thank you.
Thank you, Jose, for the nice introduction. I hope the screen can be seen. All right, perfect. Yeah, ladies and gentlemen, it is a great pleasure and honor for me to be part of this event tonight, and yeah, present some cases that have been conducted in my practice in Innsbruck, Austria. So to give you a little overview about tonight's presentation, I'm going to share 3 different cases. The first case was the one from China. It has to do with the application of the D.I.M.S technology in a high-risk convergence insufficient Asian girl. Case 2 has to do with the temporary axial regression as a treatment success indicator in myopia management. And last but not least, I'm going to share a case about the application of the D.I.M.S technology combined with low-dose atropine. So to start off with case one, this case describes the symptoms of a 6.5-year-old Japanese girl that has been dealing with some blurred vision at a distance associated with a intermittent diplopia with prolonged reading time. The symptoms had a duration for a little over than 6 months, and at the time this girl first noticed, she was actually still living in Japan. Her father, by the way, also a high myope, had to relocate to Austria for professional reasons. And yeah, this is how this little girl came into my practice. So to give you a comprehensive overview about the case history, I'm going to now share some details. As I mentioned before, the ethnicity of this girl was Asian. She's now 6.5 years old. As she noticed the blurred vision 6 months ago, a high progressive rate might be indicated because she was seeing well this 6 months ago. Both parents were high myopic. The mother was a 5.5. The father was a -6 on the right and a -7 on the left side. She hasn't been wearing any corrective glasses or contact lenses so far, as she was busy with moving from Japan to Europe. Which was good is that her outdoor exposure time was fine. And what was a bit of a concern was that she had a lot of close workup time. She had, 2 hours of homework a day. They had to learn German, and this is not the most easy part. And but her mother was well aware of myopia management and limited the screen time from the iPad to 1 hour a day. So when the girl first came into my practice, she showed up with a decreased visual acuity at distance. The right eye was limited to 30%, the left eye was limited to 40%. This decreased visual acuity could be brought back with a myopic refraction of 1.25 with 0.5 cylinder on the right side and 1.25 with 0.25 on the left side. The axial length, when adjusted for age, gender, and ethnicity, was in the 95th percentile. And what we do on every child in our myopia management, we check for binocular vision. And I'm just gonna walk you through the examination. What we saw in the distance on the cover test was an orthophoric state. The cover test at near revealed 14 prisms of exophoria, which didn't change much with plus lenses. So a low gradient ACA ratio was present. The near point of convergence was limited to 20 centimeters. The near point of accommodation tested monocularly was, we had a blur point on 10 centimeters. Positive fusion reserves in the near was 8 blur point, 10 break point, 6 recovery point, and the divergence testings were 12, 14, and 12. She was in a lead of accommodation on both eyes, and also on the facility testing of the accommodation, she showed binocularly no plus acceptance, but was clearing the minus lenses really well. And this changed when we tested monocularly. Here she was clearing both minus and +2 lenses with 8 cycles per minute. So to the diagnosis, we diagnosed this little girl with axial myopia in the 95th percentile associated with a partially symptomatic convergence insufficiency. And if we put these two facts together with the fact that her mother and father were both high myopes, she was a girl, she had a lot of near time, and of course the Asian ethnicity, a high risk profile for further progressive myopia was established for this girl. Based on this diagnosis, we created a treatment strategy. So in order to avoid any exophoric shifts from putting her from glasses to contact lenses, we decided that a glass option would have been the first treatment of choice. And I stuck with the D.I.M.S technology because I've been working with this lens for a long, long time. Together with the glass option, we established also a 12-week training program for her partially symptomatic convergence insufficiency. We closely monitored the girl. She came in for vision therapy anyways, but yeah, like the big follow-ups where we checked up the axial length and the refraction were every 6 months. And next to the myopia strategy, we also instructed visual hygiene, of course, as we already know, the 20-20-20 rule, not too much screen time, and yeah, going outside. So to the tolerance and the treatment results, the girl wore the lenses almost 24/7 as she really enjoyed the good distance vision again. The vision therapy was performed with the D.I.M.S lenses on the nose. We didn't do any over or under correction with the D.I.M.S lenses. We just gave her a good binocular correction with a good standard where she could work on her binocular vision. What was good to see that her symptoms in binocular vision decreased week by week as the fusional reserves were building up. And this, together with the spectacles we choose and the other treatment strategies, this led to the result that we didn't see any significant axial elongation throughout this really critical age period, as you can see in the percentile graph at the bottom of the presentation. So now, of course, we need to discuss a little bit about this case. I think in this case, we did a really good job so far, but the important thing that we are not finished, as this girl is still in a really critical age period where her myopia can further progress. And I think we should keep up with the myopia management as long as her age will decrease her risk profile. And of course, the axial length stays stable. In this case, we saw that the treatments results were pretty good. And I think in practice, we should not communicate that we won't, like the myopia won't change. I think some sort of normative eye growth is normal, and this should also be communicated with patients and parents that some changements also, of course, in the axial length will be normal. What we want the ametropic eye growth as a main treatment goal. And last but not least, binocular vision for me always has been and always will be really important, as it not only allows me to create really accurate risk profiles, it also allows me to further adapt and readjust for treatment strategies. In case 2, we're gonna start right away with the history of the anamnesis. Here we had a 8-year-old Caucasian girl that was referred with a cyclorefraction of 1.25 on the right side, -1 on the left side from her local ophthalmology into my practice. The axial length was above the 99th percentile for this young age. And here we had a high parental myopia. The mother was a -14. This was the bad part of the family history. The good part was that she's in the normal range with the outward new work time, and her binocular vision was normal to a point where we screened her. She also hasn't been wearing any optical correction. That's why she got her first treatment, which in this case also was the D.I.M.S technology. On the left side, you can see the percentile curves. On the right side, you can see the follow-up visits of the refraction. And I think the most interesting part here occurred during the first year, where we saw a sudden drop in the axial length, which we see on the percentile curve, which was also associated with a hyperopization in refraction. After 1 year, the axial length regressed back to the baseline measurement, and then the myopia was kept pretty stable, as you can see in the percentile curve and also in the table with the refractions. And of course, now here we need to discuss how a temporary axial length regression can be explained. And in practice, of course, we find different explanations for this. The first one could be the most obvious one, was the biometric measurement wrong? I think in this case, this was not the case, as the measurements of the biometry were backed up with the refraction. And we do know, of course, but from studies that some standard deviations in the biometric measurements are normal. The second reason could have been that she got the lenses in spring, entered the summer season. We know from the science, from the COMET study, that some progression in summer will be lower. This could have theoretically been the case in this girl, but if this would have been the case, we also would have needed to see the summer later, and here she didn't show any regression. And then last but not least, we communicate a lot about the thickening of the choroid thickening response, which is associated with shortening of the eye. And we've seen this in a lot of studies, orthokeratology, especially orthokeratology associated with atropine 0.01 when combined. Then we saw it in red light therapy, in D.I.M.S technology, of course, we've seen it as well. And to better understand it, here we have the cascade of the hyperopic defocus. And as we know, if the eye gets projected with a hyperopic defocus, we have a different encoding signals in the retina, which can lead to different fluid and ion transportations in and out of the retina pigment epithelium. And this can be associated with a thinning of the choroid. This then can remodulate the extracellular matrix of the sclera, cause fibrosis of the sclera, and then lead to the axial elongation. If we project a myopic defocus, we see that this cascade can be altered in a way that the choroid does not get thinner, but it gets thicker. And then, of course, scleral remodeling and fibrosis of the sclera can be altered. And here we do see also axial elongations that decrease. To fully understand it, I think in this case, a mix of all three possible reasons would have been the case, because the right eye dropped to almost minus 0.6 millimeters, the left one half of it. And now I'm gonna just come to the practical part, as a practitioner, and this is really important to mention and see a lot in practice. And I think that these cases are really good, and that a drop and then a rise of the axial length is kind of a reaction of the eye to the sudden shock myopic defocus it gets. And for me in practice, this is a really good treatment indicator, as I do see that if I have this drop, not even that big, then in this case, but I've seen it also in ortho-K, also in atropine especially, and then the regression again to the baseline measurement, that this is associated with a good success in myopia management. If I don't see this effect, I do have more progressions in myopia management. And what's really important to mention, if at all, I'm an expert, and on the study pyramid, I'm on the bottom. I do know that, of course, that there's no study that backs this up. But yeah, kind of to give the scientific part also ideas for future perspectives. Should we standardizedly measure choroidal thickness? If we measure the choroidal thickness, how do we measure it? Do we measure it how you see it here in the bottom right picture by hand? Or should we measure it or let it measure by an artificial intelligence? We do know that thicker choroids clearly show less progression on myopia. And then, of course, if we gain more knowledge about this topic, we would probably also be able to tell or answer questions like how much choroidal thickness would we actually need for a stable axial length, and maybe some growth charge associated with choroidal thickening and axial length would be the future here, which I would really look forward to. And then we already reached the last case. Here we had a Caucasian girl. She was 9 years old. She came in with a refraction of -1 on both eyes. In this case, the axial length was in the 75th percentile, so lower than in the other two cases. She had a myopic father with -2. She also hasn't been wearing any corrective glasses so far. Outdoor time was in the normal range. She had a high near work time, as she already was using a smartphone, but also here binocular vision didn't show any abnormalities. What we did with this girl, we got her D.I.M.S technology again, and on the left side you see again the percentile curves in the first year. On the right side, you see the table of the refraction. And what's really interesting in this case, and we see this also in science, that there is not a good correlation of the axial length, because she was basically increasing 0.2 millimeters in 6 months and didn't show any changes in the myopic refraction. And this occurs a lot in young children, that the correlation is not always backed up. What we did see, and therefore we let it there, that the myopia was stable the first half year, but then she gained further axial lengths and then was myopicizing 0.75 within the first year. Of course, here, when we communicate with parents, we always have to tell them that we are using an evidence-based product that, on average, should alter the axial length progression for 60%, a little more than 60%. And if this lens doesn't work, I honestly would not have been the practitioner that didn't do anything, because this girl would have been progressed even further. What we did with this girl then was added atropine 0.01. This is now 2 years ago. There haven't been a lot of studies out at that time that had the association with D.I.M.S and atropine, but we knew that this would work from orthokeratology trials, and this is why we did that with the girl. Now we're in a different situation, because a lot of studies with combination treatments are out there. And what we saw here as well, after 6 months, again, as in case 2, we had a slight decrease of axial length, which was also backed up by the hyperopization again. Then the myopia was stable, and then after 1 year, she was at the baseline level where we left her. The girl started with a moderate risk profile, turned into a high risk profile, but then was stabilized 1.75 diopters. And this is already the end of my presentation this evening, but I would like to leave you with some takeaways. I've been involved in myopia management for the past 10 years now, and I've kind of always dreamt of a situation where we can provide every myopic children with the right proper treatment. And it is the time that has come now. We have a lot of different treatment options. We have a lot of knowledge about these treatment options. And if you haven't started, you should really start now. You're changing children's life to the better here, and they're doing something good for their future. The second thing, you saw it in every case now of these 3. If I have a risk profile of the kids that are already high or moderate, for me, early intervention is crucial. I do not wait for the myopia to progress. I think this is the responsible way to do. We have science that backs everything up that we do. And we've waited the myopia to progress for far too long. And now I think if we have a high risk profile, we should start right away. Then, of course, my myopia management has an approach that I do a risk profile based myopia management. Here, as Pascal mentioned initially, every child is different and we need to treat it differently. We're working with children here. And last but not least, for high-risk patients, I always prefer good evidence-based products, as especially with the high-risk kids, I do not want to waste precious treatment time with products that are not that efficient. Everyone wants a cake on the myopia management, but every company, but I think evidence-based approaches should be the first treatment of choice. And as the last case showed, there is a constant evaluation and readaptation for your myopia management. Combination treatments work really well nowadays and are backed up by science. And this is what you can do in high progressive kids. For now, here we have the sources. I would like to thank you for your attention. Of course, if there are questions, I will stay online. But you can, of course, also reach out to me via email or LinkedIn. Thank you very much, and back to you, Jose.
Thank you very much, Max, for this excellent and concise message. Now the floor is for Daniela. Please, Daniela, you can share your screen and start your presentation. Remember that in the end, we will accept questions. We have already some in the Q&A, and we will address those, or at least the most burning questions to the panelists. So keep with us and continue enjoying this beautiful session. Okay. Very good. Thank you, Daniela. We are seeing your screen now.
Thank you for the invitation, and thank you for your kind introduction. Thank you, Hoya. Thank you, Max. Your presentation was very, very good. I appreciate it. And my ideas are also the same. And I hope that people already will know better to answer to my question based on your recommendation. But for the beginning, I want to point almost the same idea that, and for me, one of the most important thing in evaluation of myopia is to measure axial length. And this is so important, as we know that myopia progression means eye growth. And the best way to measure eye growth is by optical biometry, which provide us an accurate reading of axial length with very good repeatability without requiring drops and eye contact. Considering that the risk of pathology comes from elongation of the eye, reduction of axial elongation is the aim for myopia treatment. As a result, axial length measurements is mandatory for assessing the risk of myopia, the progression, and treatment effectiveness. In my practice, I always have in mind and on my screen the Tiedemann growth chart, and this tell us the risk of myopia and the risk of high myopia. For example, for a child or a boy of, sorry, do you see my point? I don't know.
Yes, we can see the arrow of your pointer.
Okay, sometimes it appears, sometimes not. Okay, for a boy of 6 years old with an axial length of 23, this means that he is on the 75th percentile, which means a risk of myopia of 60%. For a girl with the same age with axial length of 22.5, the risk of myopia is 70%. These graphs also help us to evaluate the risk of high myopia, and for every child over 95th percentile, we know that there is a risk of more than 16% to have high myopia, and we have to act more aggressively. We start from the normal growth of the eye, and we know that for emmetropic children, axial length increased between 7 and 10 years old by 0.1, 0.2 millimeters per year, and between 11 and 16 years, the progression of the emmetropic eye is 0.1 millimeters per year. For myopes, before 10 years old, the progression is 0.3, and for myopes is 0.2. Our goal is to have a progression in myopic children the same as in emmetropic children, considering that a child grows and the eye is normal to grow, grows also, and we have is a minimal axial elongation is acceptable. For that don't use these measurements, maybe you know, it is accepted that 0.1 millimeters elongation means approximately 0.25 diopters in diffraction. Our goals in myopia management are to prevent myopia onset and high myopia. For the first goal, we have to act in pre-myopia. For the second, we have to decrease myopia progression as soon as possible. International Myopia Institute offer us the definition of presmyopia, a refractive state of an eye of less than 0.75 diopters and more than 0.50 diopters in children where a combination of baseline refraction, age, and other quantifiable risk factors provide a sufficient likelihood of future development of myopia to merit preventive measures. And this is very important that now we have some treatments to prevent myopia. But for this, we have to evaluate the risk of myopia onset. And these are the risk factors. And two of the most important risk factors for myopia onset are age before 9 and refraction that shows more minus than expected for the age. For example, a refraction less than plus 0.75 before age of 6. Zatnik demonstrated that refraction alone, even in absence of other factors, can predict future myopia. Other factors are family history, at least one parent with myopia, ethnicity, East Asian race, and lifestyle with too little time spent outdoor, less than 1.5 hours, and too much on near work. Regarding axial length, a value over the 95th percentile and an axial elongation of 0.3 millimeter per year was recorded before myopia onset, and these are also very important risk factors. About binocular visions, esophoria, increased accommodative lag, and higher ACA are a risk factor, especially when they are combined with smaller hyperopia. Let's introduce you Clara. She is a 13 years old teenager with low unilateral myopia. I ask myself, and I will ask you too, whether to treat or not one or both eyes. You can see here her refraction. On the right eye, she has -1, and the vision was 0.4. And the left eye has a very good vision, and refraction is almost 0. The axial length, 24.8 in the right eye and 24.3 in the left one, confirms the anisometropia. When we look on the graph, the right eye is on the 98th percentile, which means a risk of high myopia of 40%, while the left eye is on the 95th percentile, which means a risk of myopia of over 90%. His myopia is in the right, his diagnosis is low myopia in the right eye and presmyopia in the left eye based on IMI definition. And in this case, quantifiable risk factor is axial length. Let's assess the risk of progression based on her history. The Caucasian origin, the age over 13, and myopia onset, late myopia onset are good, are positive elements, while family history with mother with myopia and lifestyle with close work over 8 hours per day and reduced time spent in natural light under 1 hour a day are risk factors. And now please try to answer to this question. You have to enter in Slido using the, I don't know in English. Please,
QR
if you
code.
want,
QR code, you can scan the QR code with the telephone.
Scan and answer to the question. I'm waiting for you to scan.
Is working, Daniela?
Yes, it works. Thank you.
Yeah. I have already digitalized my own, and it's working perfect.
Okay, most of you recommends D.I.M.S. I think that almost all answers are correct without one, except one. And in my opinion, the wrong answer is no correction. And nobody said no correction. And the reason for that is that the vision was 0.4, and we know that under correction and no correction favor myopia progression. Thank you for your answer, and now I will give you my opinion about this treatment. For the right eye, D.I.M.S lenses are a good choice considering the efficacy and safety, but considering the good vision in the left eye, I have concerns about compliance. Ortho-K lenses could be prescribed if we use a customized design. A soft multifocal contact lenses for the right eye with a good addition, a high addition, could be even preferred for low myopia. Atropine is a choice for those who are not able to prescribe myopia control spectacle, but I don't like to start with this type of therapy as the child still need visual correction. Combined therapy is recommended over 95th percentile, but I don't like to start with combined therapy because in this way I will not know the efficacy of each treatment. For the left eye, there are no studies about the D.I.M.S in myopia to prevent myopia. We have no studies on this subject, but I expect to have the same good result as in myopia through myopic peripheral defocus, the same mechanism like in myopia. And there are some studies that demonstrated that there is hyperopic peripheral defocus in pre-myopic children, and this lens could prevent myopia in this way. Contact lenses outside are not appropriate for this child, but atropine could be a very good solution considering the LAMP2 study, which demonstrated that the onset of myopia could be delayed using this atropine 0.05%. The combined treatment is not appropriate. What I chose was MyoSmart in the right eye and conventional plano monofocal lens in the left one. I chose this because I was worried that if she had not felt comfortable with the glasses, she would not have worn them at all, and I would have lost their positive effect on the right eye, and I insisted that the spectacles should be worn all day, and I explained the risk of high myopia. Proper education about lifestyle, importance of the outdoor, sleeping and reading habits was reinforced, and I usually like to recommend this reading position on the sofa, which favors higher and equal distance between the eye and the book. But also all this position could be accepted if the girl can do that. Follow-up was set in 6 months. And here is amazing results for me. In the right eye with MyoSmart, the refraction decreased by 0.25 and axial lens decreased also with almost 0.1 millimeters, while in the left eye with conventional lens, refraction increased by 0.25 diopters and axial lens by 0.1 millimeter as expected. In this moment, I recommended MyoSmart in both eyes, and after 12 other 6 months, The right eye was stable, while in the left eye, axial lens decreased a little by 0.04 millimeters. Here you can see the evolution of the eye, and this case is very important for me, as we rarely have the possibility to evaluate the efficacy of different treatments in same patient. Moreover, in real life, we cannot clearly assess if the success was due to the treatment or to natural evolution or to both. This case proved the efficacy of Myosmart as myopia decreased in treated eye and progressed in the case control congenital eye in the absence of treatment. In addition, it offered a rare opportunity to assess the success, that the success was due to the treatment, not to natural evolution, which is amazing. The growth chart dictates the need of the treatment. In case of unilateral low myopia, but with risk of high myopia, the treatment should be started in both eyes from the very beginning. Myosmart lenses may be well accepted and efficient even in pre-myopic teenagers. But the compliance is very important in these cases. And I will show you Darius' case. He is a 12 years old boy with low myopia in the right eye and with the rule myopic astigmatism in the right. Again, the question is to treat or not to treat. And you can see the refraction in the right eye minus 0.5, in the left eye a small astigmatism with the rule myopic astigmatism, and axial lens about 25, which means that he is over 95th percentile. The risk factors for myopia are lifestyle and again axial lens over 95th percentile. I started in this case with Myosmart in both eyes, but after 3 months, because I asked him to come very soon, the axial lens increased by almost 0.1 millimeters in 3 months, and this was I was very concerned about this, and I expressed that to the child, and he admitted that he hadn't been wearing his glasses. And again, I discussed and I explained that the glasses should be worn permanently, and I explained also that an increase of 0.1 millimeters in 3 months could mean 0.4 in 1 year, and if it had a linear growth, in 3 years, it could reach an axis of 26 millimeters and a myopia over 3 diopters. After other 3 months, the axis did not change significantly, and after 1 year of consistent wearing of Myosmart glasses, the axial growth was 0.01 and almost nothing in the left eye, without changing in cycloplegic refraction. I forgot to say that in case of premyopia, I prefer to use cyclopentolat for cycloplegia, but in case of myopia, I prefer tropicamide. The takeaway message, again, the growth chart dictates the need of the treatment. Axial lens measurements highlights progression before it is evident on refraction, and we can change the treatment even sooner if we measure axial lens. Myosmart lenses are effective, of course, only when they are worn. When we talk about high myopia, the patients see glasses with thick lenses and imagine that the surgery will solve all the problems. But for us, this means severe damage to the eye, the risk of severe damage to the eye, and through maculopathies or retinal detachment, which refractive surgery obviously does not solve. Brian Holden Institute states these factors that increase the risk of myopia progression: the age before 9, parental myopia, one or both parents with myopia, East Asian race, refractive error with more myopic than age normal, and progression worse than minus 0.75 diopters per year. One therapy is not enough when progression is over 0.1 millimeter or more than 0.25 diopters in 6 months under one optimized treatment, like, for example, atropine. We have to check the compliance and we can increase the dose. For soft multifocal contact lenses, we can increase the addition. For ortho-K, we can decrease the optical zone and increase the defocus. And for myopia control spectacles, we have to check the position of the frame on the in front of the eye. In such cases, we just add another therapy. Usually, we add atropine to an optic method of correction. But there are cases where it's better to start with combined therapy. And in his book, Managing Myopia, One Child at a Time, Langis Michaud recommend to start with combined therapy when we have a patient with high risk. This means over 95th percentile and fast progression over 1 diopter per year if the child is under 10 years old. And now I introduce you Robert, a 9-year-old boy with low myopia with risk of high myopia. The question will be monotherapy or combined therapy. His cycloplegic refraction made with tropicamide was -1 in the right eye and -0.5 in the left one. The axial lens, 24.4, put him on the 95th percentile. The risk factors for progression are young age, myopia onset before 9, and long axial length. The question is, how would you treat him, considering that he is not interested in contact lenses? Please vote. Most of you recommend D.I.M.S plus atropine, a combined treatment from the beginning, and other prefer D.I.M.S and less single vision and atropine and other atropine. Thank you very much for your answer. And another question, when do you schedule the first follow-up visit? Thank you. I agree with this very short interval for checkup, and I will, okay, 70% at 3 months. I do the same. I recommended just MyoSmart, and I asked him to come in 3 months. And after these 3 months, the axial elongation was 0.1, which is too much in my opinion. Even the child wore the glasses consistently. And in this case, I add atropine, 0.025%, and I was, after 6 months with combined treatment, the axial lens decreased a little, 0.05, 0.03, and the result was maintained over 3 years. The refraction didn't progress, and I didn't say when it's not written in the table, this means that I didn't use cycloplegia. I noted just refraction with cycloplegia. And after these 3 years, the axial growth remained 0.1 millimeter, which was recorded before the addition of atropine. It was no progression with combined treatment. This is his evolution on the axial lens. Myopia was stable with this combined treatment. And what is very nice is that axial lens shifted from the 95th percentile to 90. This is a very good result. The message to take away, the growth chart dictates the need of treatment before the progression on refraction. We can start with monotherapy only if we measure axial lens and follow up very closely. Adding atropine may improve the effectiveness of MyoSmart treatment. And the last case is Marios with high risk of high myopia. Again, the question is monotherapy or combined therapy. I met him when he was 5.5 years old, and he has mixed with the rule astigmatism. And after 1.5 years, he had compound myopic astigmatism. His progression was about 1 diopters in this interval. MyoSmart glasses did not exist at that time, so I recommended atropine 0.01%, which was generally used at that time. But he came after 2.5 years, and his progression was about 3.5 diopters, and the axial lens is 26.7, which is more, is well over the 98th percentile. Except the fact that she's Caucasian, he had all the risk factors. Is young, myopia onset before 7, mother with high myopia, everything is there. And I ask you, what do you recommend for him? Again, not contact lenses. Okay, thank you for voting. Most of you recommends D.I.M.S plus atropine 0.05%, and just 3% just recommend D.I.M.S alone. I will show you what I chose, just MyoSmart. One reason for that was that the mother did not accept the treatment with atropine, but also I like to see the result with just one treatment, and if the child comes soon enough, it's not so bad to start with monotherapy, in my opinion. And in this case, after 6 months, myopia did not increase and axial length significantly reduced. So I was very satisfied and maintained the same unique treatment. And one reason is that, as Max said before, it was noticed this reduction in axial length in all treatments that I also use in myopia management. For example, in this graph, you can see my results when I started to work with D.I.M.S, and after 6 months, I checked 40 children, and 18 of 40 children showed axial shortening after wearing MyoSmart, visible as downward slopes on the graphs. You can see all the slopes down, 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 and I am very happy when I observe this type of evolution. Max already explained that this is due to thickening of the choroid. But I continue my study with D.I.M.S and I evaluate 120 children, and I go with this with the results in China, in Sanya last year, and I noticed that axial lens shrink at the beginning of the treatment predicts better evolution, as I found a positive correlation between axial elongation at 6 months and 12 months in D.I.M.S wearers. You can see, it's not easy to go on the slides. I would like to, okay, here, when we have, here is in 6 months, and when we have a decreased axial length, minus 0.2, minus 0.1, after 12 months, we also have a better result than when we have an increase at the beginning of the treatment. Another important point that I noticed in my study was that baseline axial length does not predict the result of the treatment for any age group, as I didn't find any correlation between the axial elongation and at 12 months and the baseline axial length in D.I.M.S wearers. Therefore, baseline axial children with longer axial length are not expected to have a worse result than those with a shorter one. And the result after 6 months, my optimism was cancelled by a significant increase of axial length. I wondered if the measurements were accurate or not, but good vision in the refraction, similar to the previous one, led me to maintain the same treatment. Here you can see the refraction that is almost the same like at the beginning of the treatment. So I recommend just Myosmart, and after 2.5 years, the evolution of the right eye is clearly positive, with an axial elongation of only 0.1 millimeters and without refractive progression. In the left eye maintains a growth similar to that of an emmetropic eye of the same age, at the same age. In fact, we cannot expect a total stop in eye growth as long as the child is growing. In our case, from 9 to 12 years old. On the other hand, from the progression of 3.5 diopters to 0.5 in the same interval of 2.5 years, we can consider that we had a great success. This is his evolution on the D.I.M.S chart, and the message is that Myosmart is also effective in cases of high myopia, even as monotherapy, and treatment should be started as early as possible to prevent high myopia. Neither refraction, nor axial length, nor even evolution before the treatment can predict the response to treatment. After 15 years in myopia management, I feel that I still don't know enough, but I am sure that we should do everything for each myopic child based on the scientific evidence that we have at this time. And there is solid scientific evidence behind Myosmart. So I encourage you to use Myosmart for children with myopia. Thank you for your attention.
Thank you, Daniela. Okay, now we have more 15 minutes or so to clarify some questions. Our attendees have been very, very enthusiastic in posing questions here, very interesting ones. So I will ask also to Max and Daniela to be very concise. Pascal, if you feel that at some point you can also jump on that, you can do it, but please be very concise on your answers so we can cover as much as possible the questions of our attendees. First one is for Pascal. Pascal, I will ask you if you can project your screen with the QR code where the studies were available, because we have someone who was asking, where can I find those studies? So please, if you can project the QR code where they can access the material, will be brilliant. Of course, this will be recorded and will remain in the professional development platform. So if you are not a member of the Academy, please consider joining us, because this will provide you also access to the professional development platform with hundreds of material there, posters, presentations, videos, to continue promoting your knowledge in this and other fields. So you can do that. The first question is for Max regarding case 2. Someone is asking if you reduce the prescription as myopia slows down in progression. Do you change your approach?
Yes.
Do you undercorrect?
Yes, we changed the refraction back to the actual refraction actually, but we kept the glasses. This was good because then the regression or progression in this case hit back. Yeah. And it was for free, as 0.05 changements from the Hoya factory get covered in the progression, and in this case also in the degression size. Pascal, please correct me if I'm wrong.
Okay, next question is for both of you. So if you can give a quick answer, if you have one, might not have it. Some people, several questions were saying, when to stop the treatment? So until which point these kids, these adolescents should wear their MyoSmart glasses or any other myopia management method? Please, Daniela, do you have a quick answer to that?
Usually, I don't like to stop the treatment. I don't stop before 20 usually, but for example, for Ortho-K at 24 or 25, and I consider that they have not. Is not a good idea to make surgery before just after 1 year without Ortho-K, because a lot of them ask for surgery when they stop Ortho-K. They ask, when can I stop and make surgery? So I ask them to stop 1 year, check that there is no progression, and then allow them to make surgery. 25,
okay.
But this depends on the axial length, because if it's on the 98, it's 25, it's 25, but if the axial length is short, we can even stop sooner.
Okay, Max?
Axial length stabilization for at least 1 year.
Okay, so keep the treatment as long as possible and be sure that the axial growth has been stabilized or normalized to physiological, let's say, situation. Thank you very much. Another question that has been replicated several times is on combined treatments. Would you consider combined treatments for every patient, only for some specific patients? So first, Max, please, can you address this question, and then Daniela?
I wouldn't do it right from the scratch. It depends, of course, of the risk profile. The younger the kids are, the better it works, the combination treatments, because the higher the risk is, but of course, I usually start with one treatment away, and then I have an ace back in my hand if progression occurs.
Okay, Daniela, would you consider combined treatments for every single patient?
The same. I don't like to start with combined treatment, just one and then add. But
very good.
Very short. Good. It's very important to have very short interval between checkups and axial measurement.
Very good. I think this is also for both, if you want to contribute, but was posted during Max's presentation. So how to manage binocular vision disorders in, for example, excessive convergence with high ACA ratio?
It depends if the patients are symptomatic or not. I think if they're not symptomatic, we observe and surveillance. And if they're symptomatic, what I usually do when they have, depending of course also of the ACA ratio, I tell them to remove the glasses when they read or do near tasks. And additionally, that's the most important thing, we also do vision therapy. But that's a personal opinion, not doing prisms on children. I'm from the American side that see the comprehensive eye involvement, and that's why I avoid prisms. But yeah, with plus lenses or removing the minus lenses, additional to vision therapy, this works really well in practice.
So just to make clear, do you mean to do binocular vision therapy, but not as a replacement of the myopia management treatment, so in conjunction with, right?
Exactly, as the other case was, yes, always in conjunction, yeah.
Okay, Daniela, any thought on this?
Yes, in these cases with excess of convergence, I prefer to use bifocal plus atropine if he's symptomatic, as Max said. And in my experience, it's not the best way to start with this, but I prefer contact lenses for these cases. Usually when I have esophoria, I recommend contact lenses.
Okay, yeah, the convergence demand will change a little bit, and the accommodation as well. Very good for both. A common question to several attendees is, could these treatments be done in 20 to 40 years old people with high myopia and still progressing? This is a burning question. Maybe in the future we will have good treatments for this. Today, I don't know. So, Daniela, for high myopia, still progressing, 20 to 40 years old, can we use the same evidence we have today to treat those patients with these devices?
There are no studies on this age, but I try to use myopia control spectacles in these cases, and we have good acceptance in young people for these lenses. We have a few patients, sometimes work, sometimes not. Okay. We can try.
Right.
They can accept. They are very motivated to accept the glasses, and they are very good wearer.
Very good. Thank you very much. Daniela, this is, well, Max, some thoughts on this question about the use in older people?
For me, myopia management, we do classify it in 4 age groups. So the first one, as I mentioned, is 7 to 12. Here, the most progression will probably occur. Then we have 12 to 16, where a little progression, of course, still occurs. Then 16 to 20. Then if they do the A levels, lot of studies, of course, also myopia can change. And then we have a small amount after 20 years old that changes. I personally did not do myopia management later than 30 years old, because if something happens, there of course can also be a pathology, the underlying cause, or near stress. And in this case, we do vision therapy, but we didn't do any myopia management on old patients at that.
Thank you. Daniela, some attendees are questioning why to use cyclopentolate in premyopia and tropicamide in myopia patients. Should you use different drugs for paralyzing the accommodation?
Yes, the cycloplegia is better when we use cyclopentolate, but it's possible to have really hyperop that have a lot of accommodation, and it's better to check with cyclopentolate. But after myopia onset, the accommodative spasm is usually smaller, and studies demonstrated that tropicamide is enough for myopic patient.
Good. So, okay, thank you very much. One question here is asking us, if you measure axial length in every myopic child as a routine for examination, even without considering myopia management or in other contexts, do you use to measure axial length in every single of your myopic or premyopic or any non-myopic patient child?
answer.
So for me, it's like the part of the basic child routine now. Even if the childs are not myope yet, we never know. And for me, it's just a great tool to use on the percentile curves. Parents are well aware of percentile curves. They know that from birth. If they get the age, not the age, the weight and the height, you can tell from the percentile curves how well or when they will end up. And this is also a tool for the eyes to use. And yeah, we do that on every child, and not only myope or not, but also on the adult patients to find out if we have high axial lengths for the further checkup of the retinal examinations in our practice. Yeah.
Okay.
I also measure axial length for every child enter in the room, and also for some adults. And it's very important to measure for adults also, because we can appreciate the risk of pathology by checking the axial length, because we know that there are patients with myopia, with low myopia, like -2 and 26, 27 axial lengths. And this make me even more careful in examination of the retina, the peripheral retina especially.
Very good. Now, a very difficult question. So one attendee is asking if there is any disadvantage in recommending D.I.M.S technology for children. What do you think?
I think not.
Any contraindication?
Yes, esophoria. High esophoria, excess of convergence is possible to be a contraindication. And I have a child fitted with a myopia control spectacles, and when I changed to atropine plus bifocal with big progression, high progression with this, and when I changed to bifocal and atropine, the result was good, was better. And it's important to check binocular vision. I chose today just cases without binocular vision problems, but they are there, and we have to be very careful about this.
Okay. Well, we have some additional questions. Some already have been answered. We could not go individually through every single question, but I think we have covered most of them. Pascal, do you think something else that we should cover in a last burning question to finish before we finish the session?
No,
or some comment you want to address?
No, I think you already gave a good last question in the room. Thank you very much, Daniela and Max, for your presentations and
Indeed.
and the answers in the Q&A. I think that was really also exciting for the audience to hear your experiences from your daily life. Thank you, Jose, for the nice moderation, and the whole team by EAO for this organization. So Hoya and we are really proud to be a partner and partnering with you together for this further education.
Thank you very much. It's my pleasure. It's our pleasure. And I'm sure that our educational committee with our chair, Daniela Nosh, in the front of this group, we will continue to work with you, work with all our partners, with our members to produce more and even better opportunities for the future. I have recorded some remarks from you both, Max and Daniela. Of course, a comprehensive ophthalmic examination, including accommodation, binocular vision, structural and functional aspects of vision, is crucial for doing a very good myopia management. Risk assessment, we have beautiful tools today to conduct that. It's important to consider age, ethnicity, gender, and other factors like the use of near and outdoor activities to evaluate, along with parental history of myopia, to consider the potential factors for fast progression. You have addressed even the potential biological cascades we are considering today to explain myopia. This is not only important for us as professionals to understand better the treatments we are prescribing, but to explain even better to our patients, their parents, and all of us in conjunction decide on the best way and on the more informative way for our patients and their parents to make decisions. And I recorded also something that both of you reinforced. the sense of urgency, and was also a matter of a strong voice in the IMC in the session that Pascal was presenting, the sense of urgency to do something today. I remember something that Brian Holden said in 2015 in the BCLA that I always repeat in every single presentation on myopia, was something like, we don't know all about myopia, but we know too much to do nothing. And I believe that Max and Daniela today did a great session. And I didn't ask the most frequent comment that was on our Q&A. Excellent session, amazing session, very important, very informative. So thank you very much to both of you and to Hoya to provide also this opportunity, and all the staff, including Christina, in our Academy Secretariat that beautifully conducts everything and put us on the air. So Educational Committee, Hoya, panelists, attendees, we still have several hundreds of people in the room, which is great. Thank you very much. Join us in May in the European Academy of Optometry and Optics meeting in Ljubljana. See you there with more opportunities for continuing education. Thank you very much, all of you.